Assalamu alaikum, everyone. Nice to see you. Thank you, Firozan, for the kind invitation and congratulations on the Liver Summit. It's been a while that I've been to Bourbon, but it's amazing, and thank you for the co-chairs. So my talk today is focusing on managing MASLD, as mentioned, with excellent talks before. I will kind of skip some of the slide. I want to be on time so that we can discuss some of the things. So these are my disclosures. I do part many clinical trials which have been either already published or ongoing, but nothing we're going to be discussing that will not be off topic. Many of you have seen this. If someone has, like as a primary care or this New England Medical Journal article, which was a very excellent review, which came out on MASLD, the main thing that Arun has mentioned briefly very well, that we are focusing on patients as a whole. But for hepatologists, the liver fibrosis is something we always talk about it. And why it's important is that liver fibrosis increases the risk of overall mortality, cardiovascular mortality, as well as liver-related mortality. But it takes many, many years to develop. Now, the new development and therapeutic strategies we are working on is stage 2 or higher fibrosis. But what are we going to be doing patients which we are seeing in our clinic with MASLD? But it takes 30 years or 35 years from someone go from like zero fibrosis. But the group of patients who have stage 3 fibrosis, we have seen very rapid progression. However, we say it takes maybe 7 years to go from one stage of fibrosis, but they are fast progressors, about 20%. Now, more interesting data about some genetic markers are coming out. We knew about PNPLA and other genes, but we will be using them in future. But the other entity, which, although we don't talk about in Pakistan, is patients who are drinking alcohol, also in addition to metabolic syndrome, and they has much higher risk of progression. Now, this is what Arun has mentioned this is multiple studies, including our New England Medical Journal article from NASH CRN, that overall mortality and cardiovascular mortality increase with the stage of fibrosis. And that is the whole reason we started focusing on that whether stage 2 or higher fibrosis, but also the liver-related mortality increases with that. Now, when we look at the comorbid conditions in MASH, which was very well managed or talked about in the prior, we are talking about billion of patients with overall steatotic liver disease, including alcohol and non-alcohol. But when you look at the comorbid conditions with obesity worldwide is 650 million, type 2 diabetes close to 450 million, and then chronic vascular disease and cardiovascular disease. So we cannot work in silos anymore. And I know that even in Pakistan that there's a good collaboration with GI and endocrinologists, but in America it's the primary care are the backbone. And unfortunately in a resource-limited country, we don't have a good network that we have primary care and preventive health care. And that's how as a long term we have to think about. Right now, we are working on treating the diagnosis. We need to identify the risk factors and working on it. And I know Zishan and other people who have been working with both sides can tell a little bit more about it. But this is a nice paper from Jeff Lazarus and talking about the journey, which is currently in all over the world, not only in resource-utilized limited country, even in the US. There is no active case finding. There are guidelines came on for screening, but not too many people are doing it. But the benefit of early diagnosis not only overall improve prognosis and outcome. Again, it's not talking about the liver-related outcome, it's the cardiovascular, future risk of developing diabetes, as Arun has amazingly mentioned. And we have to start at very early age. We need to have better quality of life and reduce healthcare costs. And I think the healthcare cost is a big impact that we have to start thinking about. So we need to involve very early on in the US. We start talking about primary care. And I have to say that most of our referrals are coming from diabetes clinics. So they are calculating FIB-4 and the primary care. So I think that FIB-4 is a good marker and we don't have to wait for hepatologists to calculate. It should be done by the primary care endocrinologist and send the patients to us. Now, obviously, I'm not an expert. I don't work here, but these are some of the challenges we have. So initially, when we used to talk about in this forum, that we all know that MASH is no longer a Western disease. We still have very low awareness of PCP and even patient. Even in fact, when you say that you have fatty liver or you are gaining more weight, it's a sign of status symbol. And then I think that's where we have to start thinking about. We doesn't have more specialists anywhere, especially in Pakistan. You don't have more gastroenterologists or hepatologists that everyone can be seen. We don't have access to fibroscan, so we need to have more idea about what other things will be available. And the cost will be the biggest thing. If you look at the income, like we can talk about people in certain community in big cities, but if you talk about everything, whether it's cost to the labs, imaging, and especially the new medication. And I would just, and correct me if I'm wrong, if you look at the cost of GLP-1, it can be anywhere from 3,000 to 5,000. That's what I think I was looking at it. It may be a little bit cheaper, but someone who is making $30,000 per month, and how are we thinking about long term that what will be the thing? And the cultural factors are very important. But the other thing is competing health priorities, that MASLD is still not considered the factor that people are scared or worried about. So we need to start integrating metabolic health into this paradigm. Now, when we look at lifestyle recommendation, this is from the talk I gave in DDW. But it's very simple. Many of you know, but all these guidelines are based on the Western. I know HepNet has a very nice paper out there, and they did discuss about the logical. But we need to start thinking about the caloric intake, weight loss, and we'll talk about. One thing, as if someone primary care, other things, that the common question, even in the US, we get asked all the time about the use of statins. The statins, again, are not only safe, it has a beneficial effect into it. But what kind of a diet we will be recommending. Now, one thing I will be focusing on is also on vitamin E. We did just completed a new vitamin E dose ranging study because there was a lot of questions about it, and I'll show you some data about it. But before we talk about the therapeutic, it's a simple thing we can do without, no matter who you are, what kind of health issues you have, metabolic health or normal, is that this is a US physical activity guidelines published in 2018, and what they recommended that every person should do at least 150 minutes of moderate intensity aerobic and 2 days of muscle strengthening. And just get an idea that this is guideline out there, taught in school. My kids in high school are talked about it. Only 26% male and 19% women met the guidelines when they last checked it. So this is something. And why it's important, so relationship of any exercise is a very steep curve. If you look at it, the people who don't move, even if you start walking about a little bit, there's a very steep curve. And this is 130 to 150, 300 minutes of moderate physical activity is where you have the maximum benefit. So any sedentary person, you start talking about person who's sitting in an office, you need to start walking around, standing up. We have these standing chair and start doing it, and I think that's important. And what's the study? So people who are physically active for 150 minutes a week has 33% lower risk of all-cause mortality. So you don't need any medications, you don't anything. So this is simple. I think even we have to talk and we have to actually be the leader, like we need to do ourselves. I think, and this is your own, everyone who is sitting in you all are very busy, we all are busy, so we need to make an effort as a family. And even in America, there are a lot of constraints. People say that it's cold out there, it's hot out there, we can't do anything. So you need to understand the barriers. And if you look at some studies that there's a clear association between physical activity and MASLD. So sedentary behavior is an independent predictor. Patients who walk average 10 kilometers less each week than those without have more. And then eat additional hour of sedentary behavior associated 1.2% higher steatosis content. So there is a good amount of data which is out there based on it. And then the EASL and all the guidelines have taken about 150 minutes and keep it less simple. I think 150, there's a whole talk I can give about what kind of exercises you can do, but there is much better. And exercise in MASLD is not related to the weight loss. So people who doesn't even do weight loss have a significant impact on liver fat, but cardiovascular health, body composition improve, cardiovascular fitness, and quality and better quality of life. And then, the question get asked, like, what is the better, whether it's aerobic or resistant exercise? The aerobic exercise improve insulin sensitivity, and resistant improve metabolic flexibility. But then there are advantages. The aerobic are very convenient at low cost and widely available, but then they can cause fatigue. So there are some resistance. So we use combination, but you need to think about, so patients who have respiratory disorders, who cannot tolerate intensive, you can do some resistant, and there are a lot of YouTube videos out there. Everyone have access to it, and we are using more and more YouTube to give it. And CDC have identified, so you need to identify in your patients if you have barriers. And this is a barrier that we have, and the first barrier is for all of us. We don't have time. But there are others. Social support is important. We don't have energy, motivation. Skill is important, and it's high cost. In America, you have to join the gym, so you need to come up with alternate. And a lot of older people, fear of injury, and then poor weather condition, but there are always ways that we have worked out. And I can share, the slides will be there, that how do you work around some of the barriers around it. And in America, a lot of time people say how when you go to the gym, people look at you, and I'm like, my physical condition, like, people can make comments about it. You need to pass that barriers, and you need to work with your patients into it. Now, the last part is the pharmacotherapy, as nicely mentioned about it, that as I mentioned, at-risk NASH, which is like Arun has mentioned, that is where the liver-specific pharmacotherapy. But patients who have MASLD alone or steatohepatitis with early fibrosis, right now, we don't recommend any pharmacological liver-specific. I get called from it that can we use resmetirom if someone is stage 1 fibrosis, right? In America, it's all driven by insurances because insurance will not cover it, it's expensive, and other things like that. So, but what does the ideal liver-specific therapy should look like, right? Essentially, all therapy we think about should be safe, it should be efficacious, and simple to use. And it has to be desirable, right? Ideally, patients want an oral pill once daily on target. But also it can be persist and has to have a good metabolic syndrome effect also, and should be cardioprotective. And that's why a lot of these medications, GLP-1 and other ones, get into it because of that reason. Now, FDA, when they started coming up with the idea which medication they will approve for MASLD, and there are two categories. One is for cirrhosis, one is for advanced fibrosis stage 2. And what they figured it out that, you need long-term trials. And you need to show on histology right now, first of all, that you can improve resolution of MASH with no worsening fibrosis, or you can have one stage improvement in fibrosis with no worsening of MASH. So when you look at the clinical trial, they use one definition, one primary outcome or other, but you need to pay attention to what. But when you approve histological outcome, then the long term, these clinical trials are still going on, whether it's semaglutide, whether it's resmetirom, because long term, they have to prove that these medications have outcomes which are progression to cirrhosis, hepatic decompensation, liver-related mortality. So that's why you're not seeing a clinical trial of resmetirom versus GLP-1 because they only have a conditional approval right now. They don't have full approval at this time. So way back, one of my mentor, and Arun was one of them, but Dr. Tony Bass was at UCSF when I became a fellow. They were finishing up, and they just published this study. This was the first clinical trial for MASH or NASH was published. It was New England Medical Journal. So it's the biopsy-proven non-diabetic patient. They used pioglitazone versus vitamin E and placebo. There was some early study on vitamin E that there was some benefit, and surprisingly, vitamin E came up with a winner as compared to pioglitazone. Also, when you look at the clinical trial, it was like, center-specific pathologists who were reading it. Pioglitazone also did really well. So I think it was just because one of the primary outcome was improvement in ballooning. When they went back in pioglitazone arm, there was not ballooning when they got into the screening, so they should not be included. So there was no improvement in ballooning after the end. So, but bottom line was 43% with 800 international units of alpha tocopherol, which is a natural vitamin E, had improvement in the primary outcome of NAS score of 2. But it didn't gain the popularity. There was a lot of question about, like, whether we can use in, there's a risk of prostate cancer, hemorrhagic shock. The dose was very high. So I think it was a brainchild of Arun and other for our NASH CRN that let's do a vitamin E dose ranging study. Let's see what we have. So we finished this 200 patients with MASLD and randomized in one of 4 treatment group, 50. And they did not require biopsy. These are all comers, and what we use as an inclusion is the steatosis, like CAP score of 260 with ALT of greater than 60. So that was, so there's no biopsy. So, and then it was treatment phase for 24 weeks and 24 weeks of follow-up. And it is just affect minimum dose to improve ALT levels. So very simple design, and this is what we have seen. Sorry, the CAP score was 280, not 260. And if you look at the primary outcome of 200, 400, and 800, if the relative change of ALT, which is pretty good, like minus 12 in that, but all the arms like did really well. And also, if you look at the normalization of ALT, which is about 50% or 49% vitamin E, as well as 800 unit. And if you look at the response of the ALT, it happened very quickly. And the one thing is interesting that even after 24 weeks, this liver enzymes pattern did not go back to the normal level. So it did persist even after that. So this was another change in that these are patient. And so the outcome of this or conclusion was that primary outcome was met with all the 3 dosages. And the lowest dose, 200, produced a very robust ALT response. So the one thing that 800 may be a higher dose and other things, so I'm using now a lower dose of 200, 400. There was no additional benefit of higher dosing. And then these findings, do suggest that vitamin E can be used as a safe, accessible, and cost. And this is not like, and data, although it's just only 24 weeks, we have seen improvement in the steatosis on the CAPS, on the fibroscan, and also some improvement in fibrosis. Although hard to, we can just publish, and this is now in submitted to hepatology. It will be published soon. So this was presented in ASLD. They may talk about it tomorrow. And lastly, I think we do mention about the resmetirom, which was a thyroid receptor. There are 2 thyroid receptors in the body, alpha and beta. Alpha is in the thyroid gland, beta is in the liver. And when most of the time in MASH, we think it's a relative hypothyroidism, so this work on this pathway. There are many other compounds in the same, and which will be likely approved in the future, but this was the first medication which improved in that one. And this was the primary trial, Maestro-NASH, still ongoing clinical trial. And the data was, which the reason they got published is that MASH or NASH resolution was seen. So there were 2-arm study, 80 milligram and 100 milligrams. So the MASH resolution was seen at 30 versus 10% in the 100 milligram, and the fibrosis improvement by 1 stage was seen. So it's not a huge difference, right? But now when they kept following these patients, they continued to show improvement in the fibrosis. So this is, and they had some beneficial effect, as Arun has mentioned, that when they're looking at it, that the hypertension, the LDL is getting better, although it was not that much metabolic benefit, but there is some benefit out there in that regard. Interestingly, this medication is also getting studied in cirrhosis. I don't have time for it. Both semaglutide and their newer agent, which have shown improvement in fibrosis, even in cirrhosis. So this is something interesting. Now, if there's a question whether I have a compensated cirrhosis, I can use it. In the Pakistan, I would say, yes, you should use it in that regard. And this is something that ASLD came up right now. I think you have to be very specific which patient. If I'm correct, it's like about 3,000 rupees tablets available, but it's still for stage 2 to 3 fibrosis. I would not use someone with decompensated portal hypertension varices right now. We need a little bit more data out there. And the one thing is I have seen actually patient with elevated thyroid levels, and that's why I just wanted to make sure if you start someone, check their thyroid level before starting it. I have seen that. And then follow fibrosis assessment with a fibro scan every year. There's selected patient, if there's a worsening on it, I would then stop on it in that regard. So lastly, I think that we will just end with the injectable, which is incretins, and then so now we have many, as we already talked about, GLP-1, GIP, and GCP. It's a pleiotropic effect right now with all the other benefit that's been going on with that liver. As we already talked about, there are many, many different trials, even tirzepatide in the phase 3 clinical trial, but there are a lot of improvement. And the Essence clinical trial, which is still ongoing, was the reason the semaglutide was approved. And then in that clinical trial, if you look at the difference between the resolution of steatohepatitis and also improvement in fibrosis, 62% versus 34%. And when you just compared the resmetirom, the placebo of the MASH resolution was 10%, it was 34%. So these clinical trials, we have to just pay attention, like what kind of it, and despite that. And then the fibrosis improvement was not that significant, 37%, but still this was at that point frame, and this longer you continue the trial, the longer it is. And as we already talked about, there are multiple different, and the retatrutide, which is like triple G, are pretty impressive. And so I still think whether it's resource limited or in all over the world, GLP-1 will be the backbone. And we are using for patients with diabetes and obesity, and we are managing even in the US, because a lot of times the primary care, our biggest issue is insurance, because it's still expensive and insurance are not. But in Pakistan, I think that is something that are using more and more. Resmetirom, I still believe in very selected population that I would using it because of the better cardiometabolic effect. And this is the reason, right? We are wanted to improve their multiple other risk factors. So these medications are causing weight loss, glycemic, lipid control, and cardiovascular, and renal, and all these other things. Actually, I think GLP-1 should be in the water. I think they're kind of doing everything right now. The only thing I would just say that this is like, who to treat. The ASLD has some guidance out there, again, from liver specific. These companies are very smart. When they looked at it, they identify in the US that 10% of the patients are not diabetic, they're not over obese or something, so there's a 10% we can only for liver specific indications that can still be used for it. Now, one thing is that sometimes we get asked who to continue, what the response and how to. So ASLD did answer that which are the group of patients. So when you're starting these medications, any medications, you should pay attention to this thing. Whether you have this decrease in the VSG by 30%, decrease in MRE, you don't have it. But the ALT is a good marker. If there's a decrease in ALT greater than 17, there is a good studies that shown that there is an overall improvement. And then we do have an ELF score. So do pay attention to that if you're using it and monitor it. And this is something that our endocrine colleagues see it all the time. The one thing is that, the retinopathy, and I think as a hepatologist, more we will be using it. We have to pay attention. If someone is diabetic and using it, talk to that to make sure. And then, this theoretical risk of thyroid, not theoretical, but thyroid cancer, and whether you have to get history. I know recently I was in Karachi, and there are a lot of med spas and other things are using these GLP-1, and I know a couple of people with pancreatitis on that, and then they had history of pancreatitis, no one asked them, I got called. So just pay attention to these things. So what it will take to control the metabolic pandemic, right? As we talked about it, we need a multi-pronged approach. We need to have a systemic investment. I think it's just like viral hepatitis and viral amylation, we have to all work together with increased awareness and improved health-related choices. We need to start at the school level, to be honest. A lot of media about the health choices. I think that in big cities, people are getting more aware of it, but we need more, having some kind of a development of care pathways. I know that there are a lot of things that the HepNet has a good paper about it. but we need to increase, like, anything, we cannot increase the burden for patient and provider, has to be cost effective. Therefore, I do like vitamin E is one of the option in early on, and enhance outcome. But local and global partnership is that because we all are in together, we learn from each other, and that is. And this is the end of my talk. And this is, I'm now looking at all of my talks. I'm putting Pakistan pictures, and I think that was the best picture from the K2. And I think it's just like, thank you, everyone.